My name is Ginger Spitzer. I'm the Executive Director for the Foundation for Sarcoidosis Research. Welcome. Thank you for coming to our patient conference. We have these, we're increasingly having these conferences all across the country, trying to get to where the patients are, which can be difficult because patients are everywhere, right? But we're so glad we were able to have one in St. Louis. If you, certainly keep your eye out for other conferences, but we're also doing another element where every other month we'll have a conference, then we'll have a webinar too. So you can also go in online and have, it's not going to be, none of them are identical because we get doctors from all different institutions to help us, etc. But thank you for coming here. It's a real testament to patient empowerment and really trying to do the best you can while you're battling this debilitating disease. Couple real quick housekeeping. Please feel free to come and go. Don't worry about interrupting or anything like that. If you have to go to the restroom or food or whatever, we do have lunch planned for later, and we'll be leaving the room and going to the lunch is being served in a different room. I think so. My staff knows better, but so that will be coming up, and then the first half is the physician's presentations. We're going to try to ask that questions after those. That questions are held until the Q&A session. So even after their presentations, maybe jot down a question if you have it. In addition, and I'll remind you, for the Q&A session, keep in mind that the physicians can't tell you what to do directly, can't provide you direct medical advice. They're simply presenting what their knowledge and their experience with this particular disease. So that being said, real quick, a few minutes about the foundation. The Foundation for Sarcoidosis Research, we're a little more than 15 years old. We had a very grassroots beginning where it was a patient and her husband, Andrea Wilson, and her husband Redding are our co-founders. She went through probably what much of the patients here have gone through. She was sick, nobody could tell her why. Everybody started telling her she was crazy. She, did her darndest to get some information, was finally able, she had a stroke, she had a heart attack, she had all sorts of, she has sarcoidosis in many of her organs. So she's pretty devastated by it. And she said, if I can get through this last heart attack, I'm going to do something about this, because we can't all just be searching around for answers where they don't exist. And so she started the foundation and began to fund research, raise money, and then turn around, give it to researchers so that they could find answers. We've grown over the years, and we also obviously do patient services. For the foundation, very often in any disease state, what happens is doctors are over here helping patients, just coming up with treatments, et cetera, and patients are over here experiencing the horror of the disease. And they only meet when the patient is sick enough to need help. And what we're trying to do is have a little more dialogue before it gets to that. So that as the physicians and researchers, I should mention, are working on drugs, what drugs are out there, what's in the market, that they can hear what the problems are before they go and develop the drugs. So instead of coming up with, they have to understand what's really the experience of the patient so that they can really understand what they should be investigating and looking at to help patients. It's kind of broad to go, well, I want a cure. Well, exactly what's going on. And this disease especially, because it's multi-organ, and they call it the snowflake disease, right? Because it doesn't present itself in everybody, in any two people the same. And so that's super difficult too. So that's the foundation's mission, is to really include patients in the research space somehow, and I'll be talking later about a registry and about our clinical studies, et cetera, to get you involved. But my experience with the foundation is, my background was in youth development. I did education programs for children, And so why am I here, you know, in a science world? And well, I went through what many of the family members go through. My husband was diagnosed with sarcoidosis, and kind of diagnosed. They're like, maybe that's what you got, you know. And so I went online, and I was looking for stuff, and I found this foundation and got some tools from them. But then also noticed they were looking for an executive director at the time to take the foundation a little further. And I met the founders, and I applied, and I got the job. But the job has become much more meaningful because of my experience with my husband. I have a little 6-year-old daughter, and I had her late. And she'll say to me, Mama, what do you do? What's your job? You know, and I say, well, I help people who are sick get the help they need, get medicines and stuff. And she's like, well, why don't they go to the doctor? And you're not a doctor. And I say, no, I know, but I have to help get them enough medicines so that the doctors can give them that. And, you know, it's kind of hard to explain it for a 6-year-old, but what she said to me was so profound. She said, Mama, if people are sick, shouldn't they already be getting help? And I was like, yeah, but guess what? You know, like, bingo, they're not. Because that was my naive understanding of the medical space too. You're sick, you go to the doctor, you get help, right? You get better, or you take whatever the treatment is to help you get better. But not here, not in this space. They often tell you, well, we don't know, or here's some prednisone, or, you know, and then you feel even worse than you did before, etc. There aren't concrete answers. There are some for some patients, but overall the understanding is lacking. The reason that it's lacking is this whole cycle of medical research. Nobody really knows what sarcoidosis is, what starts it, what, you know, what is it a genetic, it probably has a genetic component to it as well as an environmental trigger to it, but exactly on a DNA level and on a, you know, a cellular level, how does that look? They don't know. Well, if they don't know, then researchers aren't going to be drawn to this field because they're like, well, they don't even know the basics about that disease. So when I'm looking at my career, I'm going to go into cancer, I'm going to go into diabetes, where there's a lot of information and I can really make a quick progress. Sarcoidosis doesn't have those basics. And so researchers don't get into it. The other reason researchers don't get into it is there's not a lot of funding for it. Because there's no answers, it's much more high risk for anybody to put money into it, for pharmaceutical to put money into it, for the government to put money into it. So they definitely are, the field is barren. And so what we have to do is populate the field, get tools built, help get tools built. And that's what the foundation does. So that being said, kind of have a good set, yeah, hopefully you have a sense of what we're trying to do, which is, you know, really a lot of different hands in a lot of different fields, and educate the patients both on your experience and the bigger picture. So I'd like to note that on the agenda we've had a couple adjustments, and the first doctor speaking will be Dr. Richard Brasington from Washington University School of Medicine right here in St. Louis, right here on campus, and and I'll introduce the other physicians as well. On your agenda, he's not listed first, but we've kind of done some moving around, as well as a couple of the doctors have agreed. We ended up having 2 cardiac sarcoidosis presentations and, I'm sorry, 2 neuro presentations and no pulmonary. So a couple of the doctors are also going to touch on the pulmonary, which we know is a big issue. So let me introduce Dr. Brasington. And, oh, here he is. We didn't plan that. That was perfect. Doctor? Please feel free to sit.
Yeah. Hi. Good morning, everyone. I really appreciate the fact that all of you came to celebrate my 64th birthday today. This is the most people I've ever had at a party, so it's really cool. Is this working? Yeah. So I'm not a sarcoidosis expert, but I have stayed at a Holiday Inn Express. So, as Ginger mentioned, I'm from St. Louis. I'm a rheumatologist here. The reason I'm here is because one of the speakers coming up later, Dr. Saketku, and I have collaborated on some projects that are totally unrelated to sarcoidosis. So why is a rheumatologist speaking today? Well, if you have lung disease, you go to a lung doctor. If you have skin disease, you go to a skin doctor. If you have neurologic disease, you might go to a neurologist. But if you have anything else, you don't really have a home. And so sarcoidosis as a disease doesn't really have a home. So my boss, Dr. Atkinson, has been treating sarcoidosis for a long time, and I kept saying, well, sarcoidosis isn't a rheumatologic disease. I'm not going to treat sarcoidosis. I don't know anything about it. And then one day somebody said to me, well, how do you find a rheumatologic disease? I said, well, it's a disease of unknown origin. It usually involves an abnormality in the immune system, and it's not cancer, and it's not infection. And then I thought, I just described sarcoidosis. So the topic that I offered to speak about is steroid-sparing medications. And so as Ginger mentioned, a couple of things that I think are really important. That is, there aren't a lot of doctors that treat sarcoidosis. Why? Because there's a lot that we don't know, and many doctors don't feel comfortable dealing with conditions where we don't know as much as we'd like to. Number two, the medicines for sarcoidosis are not very well defined, and the way that I come in is that if somebody has a problem that gets better on prednisone or other steroids and they need some other medication, what do we use? Well, rheumatologists are really the experts at using these steroid-sparing medications, and we use them mostly for rheumatoid arthritis and lupus and vasculitis. And it turns out that some of them will work for sarcoidosis. Now, as Ginger mentioned, there aren't big studies that we can turn to for evidence. Drug companies aren't going to develop drugs for sarcoidosis because there aren't enough people for them to make a profit. So what we try to do is to adapt the medicines that we know how to use anyway and apply them to sarcoidosis. And so I decided to speak without slides today because all the slides I have are for physicians, and I thought it might come across better if I just had a conversation with you about these agents. So there are several medications that we use. One is called Methotrexate, M-E-T-H-O-T-R-X-A-T-E, or I abbreviated MTX, so I don't get writer's cramp. Methotrexate has been around for a long, long time as a chemotherapy agent, and it's still used for cancer chemotherapy. But about 30, 35 years ago, some pioneering rheumatologists got the idea that it might work for rheumatoid arthritis. One of them was my teacher when I was in rheumatology training, and we all thought he was crazy because he was giving a cancer drug to people with rheumatoid arthritis, which is bad, but it's not a life-threatening illness. And to make a long story short, it turned out that methotrexate is very effective, very safe, and very well tolerated. So it has really become the most well-established drug for the treatment of rheumatoid arthritis. So it is a logical medicine for us to consider for another disorder of unknown cause. So although it can cause lung toxicity, we don't typically use it when people have lung problems, but it's often the first drug we think about for other situations. It's actually a pretty easy medicine to take. It's taken once a week. If you take it every day, it's pretty toxic, but if you just take it once a week, it works quite well. And we're generally using doses between 10 milligrams and 20 milligrams once a week. And it comes in 2.5 milligram tablets, so we start with 4 tablets and aim for maybe 10 tablets. It can also be given as a weekly injection. And it's quite well tolerated. Some people will develop mouth sores or diarrhea, nausea. Sometimes people can have a little hair loss that's reversible. We follow lab work once a month for the first few months and then gradually spread that out. And the vast majority of people who are started on methotrexate can continue to take it. So it's really a an excellent thing for us to have in our armamentarium. It generally takes about 2 months to work, and at about the 2 to 3 month period, we generally have some indication of whether it's working. And one way we can tell is that if a person is doing okay and then is able to reduce the dose, then it's working. So I actually I work with the eye doctors, and I have several patients who have sarcoidosis, inflammation in the eye. And using prednisone or steroids for the eye is kind of a problem because it can bring up pressure in the eye and cause glaucoma. So we use it quite a bit in ophthalmology patients. Another medication that's really kind of become an all-purpose steroid-sparing agent, it's probably easiest to call it CellCept, C-E-L-L-C-E-P-T, or I abbreviated MMF for mycophenolate mofetil, which is almost impossible to say and equally hard to spell. So this is a medicine that was invented to treat transplant rejection, probably 30 years ago, and it just didn't work very well. But rheumatologists got interested in it about 10 years ago, and that's because it turns out that it works very well in lupus, which is another disease of unknown etiology. So it is particularly favored for treating lung problems. We may use that as a steroid-sparing drug in that situation. Now, I'll qualify that by saying that I don't treat people with lung problems because the pulmonary doctors are really the experts. But if we're treating a problem in the eye or the brain or something else, that's another medicine we would commonly use. Why? Because we have experience with it. It works for other disorders of immune abnormality, and it's pretty easy to take. The main problem is diarrhea. Like methotrexate, you don't want to be taking it during pregnancy. And CellCept or MMF is a little bit more likely to cause what we call opportunistic infections. And so what I mean by that is an infection that healthy people don't ordinarily get. And so there is a virus called CMV, which stands for cytomegalovirus. And that virus can cause colitis and sometimes can complicate treatment with MMF. The most interesting set of medicines are ones that were really developed for rheumatoid arthritis. And they are called we'll just call them the anti-TNFs. TNF stands for tumor necrosis factor. It's a bad name because TNF doesn't have anything to do with tumor necrosis, but when it was first discovered, it did. Nobody's gotten around to give it a better name. So TNF is a very important inflammatory molecule. And the really neat thing about these treatments is, unlike methotrexate and CellCept, which have very broad effects, the anti-TNF drugs target one molecule. They only hit that one molecule. It's a very, very specific treatment. And it turns out that rheumatoid arthritis and psoriasis and Crohn's disease and sarcoidosis sometimes involve increased TNF levels. There's another reason why it's a particularly good choice, and that is because sarcoidosis, you may have heard of, is a granulomatous disease. And all that means is that granulomas are part of the pathology. So what is a granuloma? G-R-A-N-U-L-O-M-A. So a granuloma is something that we describe when we look under the microscope. And this kind of inflammation is unique because you get something called giant cells. And these giant cells are basically a bunch of smaller cells that kind of merge together to form a clump. It's good we have that because if you get exposed to tuberculosis, your body will use these giant cells to corral the TB and keep it from getting out. So, TNF is very important in maintaining the granuloma. So it makes sense in a granulomatous disease, some people might have too much of this stuff. So we have 5 of these medicines 4 of which can be effective in sarcoidosis. And the good news is they work very well. The bad news is they're extremely expensive. They're proteins, which are very hard to manufacture and purify. And because they're expensive, it's a challenge sometimes to get an insurance company to cover the medication for a disease for which it's not FDA approved. So if I want to provide it or prescribe it for rheumatoid arthritis or psoriasis or ankylosing spondylitis or Crohn's disease or whatever, there's no problem. But if I want to prescribe it for somebody with sarcoidosis, then I've got a pretty tough job trying to convince the insurance company. And often we can do that. You may have heard of something called biosimilars, B-I-O-S-I-M-I-L-A-R-S. Biosimilars are basically, quote, generic versions of drugs like these anti-TNFs, which are sometimes referred to as biologics. We actually kind of got away from that term because shortly after they came out, we had Gulf War #1, and people talked about Saddam Hussein using biologic weapons, and we didn't want people to associate biologic weapons with biologic drugs. So they're sometimes not called that, but you'll see writing about biosimilars, and they'll probably be somewhat less expensive. Another medicine that's been around for a long time is called azathioprine, A-Z-A-T-H-I-O-P-R-I-N-E. Azathioprine is another medicine that was invented for the treatment of transplant rejection. It's been around for a long time. In fact, in 1975, when I was getting ready to go to medical school, I worked with some kidney transplant doctors, and they were using azathioprine back then. So it's got a long history of use, and we really know how to use it. It's taken once a day. We have to check blood tests and chemistry tests. It does increase the risk of infection somewhat. Although for all of these medicines, the risk of infection is much lower than it is if you're taking a large dose of prednisone. So we're always trying to get the prednisone dose as low as possible for anything that we treat, but we usually like to try to get it down to in the neighborhood of 5 milligrams if we can. My wife has rheumatoid arthritis. Her doctor has her on 5 milligrams of prednisone, and that's, you know, it's not perfect, but it's not too risky. So there are other medications which might be used. The 4 that I've mentioned really have the best track record. If I'm seeing somebody and I say, gee, what do I want to learn from the experts about this? And I go to the medical literature, you just don't see big studies on these. And basically what you have is what we sometimes call eminence-based medicine, which is kind of a play on words. Evidence-based medicine is practiced according to the results of scientific studies which were very carefully done to answer specific question. But eminence-based medicine refers to listening to what the experts say and doing what they do. So that's most of what we're dealing with here. Another drug, which is the most risky of all the medicines I'll mention, is called Cytoxan. C-Y-T-O-X-A-N. It's actually available as a generic, but cyclophosphamide is a lot harder to say. And so I have one lady with a very bad sarcoidosis in the nervous system, and Cytoxan has really been the only thing which has helped her maintain her status and not get worse. It can be given by mouth every day, but that's very toxic, so we prefer to give it intravenously every 1 to 3 months. And the reason we have to be really careful with Cytoxan is it can damage the bladder. And the first thing it can cause is something called hemorrhagic cystitis, which just means the lining of the bladder starts bleeding. And I actually had one lady die as a result of that. I wasn't treating her for sarcoidosis, but this led to severe infection, and she died of that. The bigger problem is that if you take Cytoxan for a long time, you're likely to get cancer of the bladder. And Cytoxan is more likely than all of the other medicines I've mentioned to cause a reduction in the white blood count. And we're very careful about that, but if we overshoot with the dose, we can make the white blood cell count very, very low, and then it's kind of like somebody who's gotten chemotherapy for cancer. They're then very susceptible to potentially fatal infections. So we have to be really, really careful with that. And sometimes we just have to stop using it because the bone marrow just can't take it anymore. The final medicine I'll mention is called Rituxan, R-I-T-U-X-A-N. Rituxan, like all of these other medicines, was invented for another purpose. It was invented to treat a kind of cancer called lymphoma. And so it's been around for about 20 years for that. And about 10, 15 years ago, someone accidentally discovered it worked for rheumatoid arthritis, and it's become widely used for rheumatoid arthritis. And it appears that it might work for lupus and some other things. And so it's a medicine that we sometimes think about using. It acts against a certain kind of white blood cell called the B cell. B is in bozo. And why it works is not exactly clear, but it kills these B cells. So without getting into a lot of detail, we don't tend to think of sarcoidosis as involving abnormalities with B cells, but it sometimes works for other conditions, so it's something that we have to think about, but it doesn't have such a well-established role. One of the key factors in drug development right now has been developing more of these extremely targeted medicines like the anti-TNF drugs. It's very possible that one of those medicines, one or more of those medicines, might turn out to be very effective in sarcoidosis. And one of the challenges is trying to study that. So let's say I wanted to study drug X in sarcoidosis. I might be able to get the company that makes the medicine to give me some to test it, but the problem is I'm going to have a pretty large number of people to be able to tell if it works better than not giving it. And a lot of places don't have that many patients in one place. So you then need to try to involve multiple institutions, multiple medical schools. That gets complicated and expensive. And as Ginger mentioned, there's not really a lot of funding for that. So that makes it very challenging. Well, I've thrown a lot of information at you. I'm going to close right now. Can I entertain a question or two since I have to leave? Because I have to go make rounds.
Yeah, let's get you questions.
Yes, ma'am.
Humira, is that a anti-TNF drug?
Yes, Humira, H-U-M-I-R-A, is an anti-TNF drug. And that is one of the medicines we think about using in sarcoidosis.
But if it...
Say that again?
I was told by one of your doctors here that the Humira I was taking for psoriasis caused my sarcoidosis. Because when I
Well, that raises, yeah.
went away.
Was it somebody in rheumatology?
Yeah, Russell. Dr. Russell.
Oh, she's in pulmonary. That's okay. Well, that raises a really complicating issue. There is another anti-TNF that's different called Enbrel. And Enbrel does not work to treat sarcoidosis, and sometimes a sarcoid-like illness can develop. So there's a lot we don't understand about the immune system and a lot we don't understand about sarcoidosis. And so if somebody develops sarcoidosis after getting a medication, we may worry that the medication was involved. And so one thing that's paradoxical, for example, is that Humira can be used to treat psoriasis. But sometimes people develop psoriasis while they're taking it. So I would disagree in general with the idea that Humira causes sarcoidosis, but I would not, if someone said, well, I developed sarcoidosis after taking Humira, I would not say, well, I'm absolutely sure that had nothing to do with it. So drugs like Humira, there is a slightly increased risk of developing a cancer called lymphoma. So it's a good question.
And Stelara as well?
So Stelara is a drug that binds to different molecules. It works in a completely different way. So probably not. Can I have one more question? Uh-oh, there's a bunch of them. Did you have one?
Yes, sir. Since sarcoidosis is a systematic diagnosis, how do these drugs interact with each other since everyone has different symptoms?
Good question. How the drugs interact with each other. Most of the time, it's not a big problem. If you're taking methotrexate, you have to be careful about taking a particular drug called Bactrim because it can interact with it. But most of the medicines I've mentioned can actually be used in combination pretty safely. It's really more a matter of trying to make sure they don't have similar toxicity. So for example, if you were to use methotrexate and azathioprine together and the liver became abnormal, it'd be a little hard to tell which medicine it was.
In that situation, what would you suggest? I'm not asking specifically yours.
Yeah. Well, so what you do if there's toxicity? Well, for example, if you're treating somebody with a medicine that might cause liver problems and you're monitoring the liver tests and they go up, you generally reduce the dose of the drug or stop it, and also investigate for other possibilities. So a classic situation we see is we might have somebody on methotrexate and their liver tests become abnormal. First thought is that it might be the methotrexate, but it could also be they've developed hepatitis C. So we have to think broadly in those terms. But usually if you have toxicity from a medicine, you can reduce the dose, or sometimes you just have to stop it. There is another medicine called Acthar, A-C-T-H-A-R. It's actually a very old drug that's been revived. It's made by Mallinckrodt. That's what made me remember it. It does not have an established role in sarcoidosis, but it is a medicine that's been around for a long time and another medicine we can think about using as a steroid-sparing drug. Okay, sorry for going over. Bye-bye.
Okay, thank you.